extraoral radiography for you all, and you all know what is extraoral. That time I had discussed this, that a radiograph can be intraoral or extraoral, right? So,
Yes, sir.
now we'll come to few basic terms. Basic terms are what is a radiograph. Okay. A radiograph is a visible photographic record on film produced by the passage of X-ray through an object or a body. So, what actually you call a X-ray is actually a radiograph. It is a visible photographic record on film. A film, a photographic record is produced, which is visible and which is made by how? When the X-ray passes through certain object or body, then we call it as a radiograph. Then what is radiography? The art and science of making radiography is called radiography. I think we have discussed all these basic things. Something known as FMRS. FMRS means full mouth radiographic survey. Full mouth radiographic survey includes, we do it usually when we need to check all the teeth in a patient. So it includes 10 to 15 periapical radiograph, 2 to 5 bitung radiographs, or 6 topographic occlusal radiographs, 2 bitung radiograph, 1 panoramic radiograph, or 2 to 5 bitung radiograph, or right and left lateral oblique radiograph and 2 to 5 bitung radiograph. So when we want to see all the teeth in all aspects, as want to assess every aspect of the teeth, then we use full mouth radiographic survey. Okay. Now we'll come to something called as periapical radiography. So basically, intraoral radiography is of 3 types. One is periapical radiography. See, basically the radiographs related to dentistry are of 2 types: intraoral radiograph and extraoral radiograph. In extraoral radiograph, we keep the film outside the mouth or near the head. In that, we have 2 types of views: panoramic radiograph or OPG, and the skull view. The skull views I have already discussed with you: PA view, then lateral views and the submental vortex views. PA view had different types of view, right? PA view, Waters view, PNS view, then reverse Towns view. Those views were there. And PA cephalometric view. Lateral, we had lateral oblique views and the lateral cephalometric views. And OPG also we had discussed. Then when come to intraoral radiography, when we keep the film inside the mouth, okay, that is most commonly used. In that, we have 3 types of radiographs: intraoral periapical radiographs, or simply periapical radiograph, which we take most of the time and we call as a IOPA radiograph, right? All of you are familiar with it. It contains the tooth and the periapical tissues. That is, the tooth will be seen and the periapical tissues will be seen. We call it as a IOPA radiograph, intraoral periapical radiograph, or periapical radiograph. And the second type is called bitung radiograph. When a bite is registered, the bite is registered means both the crowns of both upper and lower teeth come in that radiograph, but the root and the periapical area do not come. Those radiographs are called as bitung radiograph. And third type is called occlusal radiograph. Occlusal radiographs, when we keep the film in the occlusal plane, then we call it as a occlusal radiograph. In occlusal radiograph, either all the interior teeth or all interior and posterior teeth, or only one side of posterior teeth will come. Okay, they use a larger film. Now, when do we use periapical radiography, right? What are the indications of radiograph? So, when we will need to see the teeth and the periapical structures or the structures surrounding the tooth, when we suspect an inflammation in the periapical area, that is periapical inflammation. When we want to assess the periodontal status of the tooth, that time we will do it. Then we want to assess the trauma. If we see that the tooth is fractured, if the fracture is near the roots or near the apex of the root, then we do, or the middle third of the root, then we make a periapical radiograph. When the tooth is unerupted or impacted, below one tooth, say a deciduous tooth is there, below that deciduous tooth, if some tooth is impacted, then we make, what do you call that? Then we can make periapical radiograph to see the area below it. When we want to see the morphology of the root, so when we will like to see the morphology of the root, when you want to extract the tooth for some reason, or you want to do root canal treatment, then you want to see the morphology. If the root is tilted or dilacerated, you know from the surgery that if you apply force, the tooth will break. So in that conditions, we need to make periapical radiography. Then endodontic treatments, sure. And for restorations, if you want to do some restoration the tooth, that time we need to make. And pre and post operative assessment of periapical surgeries. Okay, whenever we want to see periapical area, we will make the periapical radiograph. So these are the indications. Many times the indications for the periapical radiography will be asked. So please remember them. Okay, fine. Now Then when there are lesions in the alveolar bone is the bone surrounding the root, surrounding the tooth and the root. So if there is a lesion, suppose there is a cyst, there is a fracture, there is a tumor developing, there is a soft tissue lesion which we suspect that the teeth might be involved, the bones might be involved, then we call it, then we take the periapical radiograph. We want to do dental implants, and if you want to assess dental caries, this is the most common cause. Now we'll see how we will make IOPA radiographs or how to make periapical radiographs. So let's see what are the positioning requirements, how we can make. All of you have seen the film of the IOPA radiograph, right? Somewhere now all of you are in third year or final year in hand of some patient in some department, you've seen the film, right? It is a small film. Most of the time we use type 2 IOPA film. I think the size and all has been taught to you and taken. The film packet is very flexible and is a small in size. Okay. How much, what is size? 33 into 43, right? So what if you want to make it, see, making the radiograph is like making a shadow. You know, if you want to make a shadow of your hand, then what? If we have to make a shadow of this tooth, shadow of this tooth on this film, shadow of this tooth on this film, the light has to fall in such a way. What all the ideal requirements are there? The tooth should be parallel to the film, right? If you want to make a good shadow of this film, exact shadow of this tooth on this film or in this wall, then this tooth and this wall have to be parallel to each other. This tooth has to be close to this wall. The light has to fall at 90 degrees and only one single source of light has to fall. Then only we will get a good radiograph, and then the all light sources should be parallel. So these are the ideal positioning requirement. This is also called as projection geometry. So first we will read what is projection geometry. Okay. So projection geometry, right? There are 5 principles of projection geometry. First is the size of the focal spot should be as small as possible. You know what focal spot is? Focal spot is the area in the X-ray machine from where the X-ray comes, or that is the source of the production of X-rays. And you know that the X-rays are divergent in nature, like the light. The light is a divergent nature. If you take a torch and focus it further on the wall, what happens? The size increases. Same way, if you want to make a good shadow, a single torch you have to display, show. You cannot have multiple torch and you have a good shadow, right? So for that, the smaller and the better the point source, single point source will give you a very good image. So the focal spot of the X-ray or the source of the X-ray has to be as small as possible. Second is that the focal spot to the object should be as large as possible. Means from the source to the object has to be large. Why it has to be large? Because if you see, I told you that the X-rays are divergent. Same way the light is divergent. So if something is divergent, suppose I'm trying to draw, this is the source and the one ray will go like this and the one ray will go like this. So if I keep the film here, the rays will be divergent. But if I come to the farther end, what will happen? The rays in the center will be parallel. Suppose this is the place from here. Okay, I'll try to take a pen and draw and show you. Okay, suppose this is the place from here the source light source is coming, so the X-rays are divergent. Okay, they are divergent like this. Okay, so if it is nearer, the shadow will be larger, it will be more divergent. But if I take it the shadow here, then what happens that the rays almost become parallel to each other. Okay, the central rays become parallel to each other. That is why I say that the focal spot to object distance should be as large as possible. Okay, I hope you understood this. I'll show you in later slides with the examples and pictures. The object to image receptor distance should be as close as possible. Okay, the object to the image receptor means where you want to make the shadow and what shadow you want to make. Means the tooth and the film or your hand or the wall or the pen or the wall has to be close to possible. If they are further, the light ray is divergent, so the image will get enlarged and you will not get a good size image. Then the image receptor should be placed parallel to the object. This is very obvious. The wall और जो object है दोनों parallel हो चाहिए. अगर वो तिरछा होगा तो shadow अच्छी नहीं बनेगी. It has to. I have the images. I'll show you all the diagrams. Then the central ray should be perpendicular to the object and in both vertical and horizontal planes, and the object should be centered on the image. These are the 6 principles of projection geometry. Remember them. Okay. Now we are coming ahead. So I'll tell you the image receptor should be parallel to the object. Now you see here, if this is this tooth and this film are parallel, then we get a Okay, if this tooth and this film are parallel, we'll get a good image. If it is not parallel, what will happen? The size of the image will become long. The size of the image will become long, so we will not get a good image. That's why they have to be parallel to each other. This is the first criteria. Second criteria I told you, okay, the same thing, the parallel thing. How do we make it parallel? We make it parallel with the use of film holders. Okay, this is a film holder is used. Okay, then the central ray should be perpendicular to the object in the vertical and horizontal direction. That is, this is the central ray. It has to be perpendicular of the both teeth and the film, and the teeth and the film has to be, see here they are not parallel. I mean, this ray is not parallel, so we'll not get a good image. And here, if it is not parallel, the image size is smaller than the object size. If it is not like this, image size is larger. See, one ray is going like this, one ray is going like this, and the image is going to be this big. Okay, if we keep the film like this, then this is bisecting technique, you forget it. Okay, and this is how it is in the horizontal plane. Every plane it has to be parallel to each other. Okay, if it is not parallel, if you see from here, what will happen? If I put a torch from here, the exactly these two teeth will come. If I put a torch from here, what will happen? These two teeth will overlap. This is very simple imagination of the what you do with the light. Try to keep two objects, two or three objects in line with each other, and try to focus light with a paper, and you will realize all the laws of the projection geometry. You will understand. Okay, okay, now you see, if we have a small focal spot, small rays will come and we'll get good image. If we have a large focal spot, lot of X-rays will come from many sources, from here, and from here, and there will be blurring of the image. This image makes it very clear that why the focal spot should be smaller. Okay, now the image should be long. Okay, this is the reason I told you. The if it is closer, the rays are divergent, so we get a shadow here. If it is not closer, if it is far, the rays are near parallel, so we get a smaller shadow. Okay, now this is the another law. The object and the image receptor should be close to each other. If they are close, the shadow will be sharp. If they are far, what will happen? The size will be larger and the blurred image will get. Okay, then it should be centered. If it is not centered on the film, what will happen? Half the tooth will come on the film, the half the film will remain vacant. Okay, this is the most common mistakes all of you do, and it is called as the cone cut. Fine. This is how we get the end up with the radiographs. So I hope that this much you have all understood, that what all should be the techniques for the radiographs. Now I'll come back to the first slide again. Here, the object and the image receptor should be parallel to each other. Object and image receptor should be as close to each other as possible. The rays should be parallel. That's why the image long cone should be long, and the rays should be perpendicular to both the tooth and the film. Okay, these are the principles for the projection geometry. Okay, if we can achieve this in mouth, we can keep the film like this close to parallel to the mouth, and we can drop the X-rays at 90 degree. We will get a very good radiograph. Making radiograph with this technique is called as paralleling techniques. Though in the mouth, most of the time it is not possible to keep the film parallel to the tooth because of anatomic considerations. You know, tooth को हम film flexible होती है, mouth में parallel नहीं रख सकते हैं. इसके लिए हम एक डिवाइस यूज करते हैं. उस डिवाइस का नाम होता है फिल्म होल्डर, और जो पैरेललिंग टेक्निक में डिवाइस करते हैं उसको हम कहते हैं रिन एक्सीपी फिल्म होल्डर्स, है ना. रिन रिन कंपनी का नाम है, RIN, और उसके आगे XCP मींस एक्सटेंडेड कोन पैरेललिंग टेक्निक फिल्म होल्डर, रिन XCP फिल्म होल्डर. आप जब डिपार्टमेंट आओगे मैं आप लोगों को दिखाऊंगा. दिस इज हाउ द फिल्म होल्डर इज. ओके, फिल्म होल्डर में एक स्लॉट होती है यहाँ पे. इस स्लॉट पे एक फिल्म लगी होती है. ठीक है, यहाँ पे हमने एक्सरे फिल्म लगा दी और पेशेंट ने इस पे बाइट किया. अब ये टीथ, ये जो स्लॉट का जो एक सपोर्टिंग वॉल है, ये 90 डिग्री पे है इस बाइट ब्लॉक, इससे बाइट ब्लॉक कहते हैं. टीथ ने इस पे बाइट किया तो ये और ये हमेशा पैरेलल होंगे. टीथ का लॉन्ग एक्सिस और इस सपोर्ट की लॉन्ग एक्सिस हमेशा एक दूसरे के पैरेलल होगी. और सो जो फिल्म लगी है इसके साथ सपोर्ट पे, वो फिल्म भी टूथ के पैरेलल होगी. तो टूथ और फिल्म पैरेलल हो गए. थोड़े दूर डेफिनेटली रहेंगे, बहुत पास नहीं रहेंगे. और इसके साथ एक छोटा सा एक रॉड बाहर निकलती है माउथ के, उस पर एक रिंग लगी होती है. ये रिंग भी इसके पैरेलल होती. तो रिंग क्या हो गई? रिंग इस फिल्म के पैरेलल हो गई, टूथ के पैरेलल हो गई. हम यहाँ पे एक्सरे मशीन को सेट कर देते हैं इस तरह से कि सेंट्रल रे यहाँ से इस पे फॉल करे। तो अगर सेंट्रल रे इस रिंग पे 90 डिग्री पे होगी तो टूथ पे भी 90 डिग्री पे होगी और फिल्म पे भी 90 डिग्री पे होगी। इस तरह से हमें पैरेललिंग टेक्निक की क्राइटेरिया पूरे हो जाते हैं। आगे बढ़ते हैं हम। ये पैरेललिंग टेक्निक की थ्योरी है माउथ में, है ना। ये बक्कल साइड है, लिंगुअल साइड है। हमने यहाँ पे फिल्म होल्डर से की बेसिस से एक फिल्म रख दी और यहाँ से हम 90 डिग्री पे इस रिंग की सहायता से यहाँ पे हम फिल्म डालेंगे रेज और वी विल गेट ए गुड रेडियोग्राफ, है ना। Okay, this is how we get a long spacer. We keep the film, the X-ray. This is the X-ray source. When we keep the X-ray source closer, we get a divergent ray. When we keep the X-ray source far, we get the near parallel rays. Okay. These are the film holders. जो मैंने आपको film holders बताया, ऐसे होते हैं film holders वो XCP instruments. Okay. ये सब बहुत सिंपल सी टेक्निक है। रेडियोग्राफी क्या करना है, पहले आपको पेशेंट को ग्रीट करना है, नाम पता पूछिए, बैठाइए अच्छे से, अपनी मशीन की सेटिंग कीजिए, ट्यूब हेड सेट कीजिए, आप अपने हाथ धोइए, सेफ्टी कंडीशंस मेंटेन कीजिए, एग्जामिन कीजिए ओरल कैविटी को कौन सा फिल्म लेना है और फिर पोजीशन करके आप रेडियोग्राफ ले लीजिए। ओके। We'll come to the radiographic technique. This is called as the paralleling technique radiograph. Now write it down. Write these names. Radio paralleling technique is also called as long cone technique or right angle technique or extension cone paralleling. It is called as long cone technique. It is called as right angle technique. It is also called as extension cone paralleling technique. It was first described by Edmund C. Kells in 1896. It was described by Edmund C. Kells in 1896. It was reviewed by Donald McCormick in 1937. In 37, the person called McCormick reviewed it and it was perfected by Fitzgerald in 1947. है ना, इतने साल लग गए बनने में, मतलब almost 50 years it took for this technique to be perfected. Okay, so this is called as the paralleling technique radiograph. Okay, film is in paralleling technique. The film is kept in the mouth with the help of a film holder. The film holder is usually keeps the film parallel to the knife, to the tooth, and film holder has a ring or position indicating device or bite indicating device, and it is extended outside the mouth. We arrange the film cone. This is the cone of the X-ray machine. You can see in this image. Okay, यहाँ पे एक रिंग लगी है और यहाँ पे X-ray machine लगी हुई है ना. We keep the X-ray machine parallel to the cone and we shoot the radiograph. It is the advantage of this technique is that it is very easy to do. Anybody can do it. आपको कुछ नहीं करना है, फिल्म को प्लेस करना है, टीथ पे लगाना है, बाहर ये रिंग लगी हुई है, उस रिंग से एक्सरे मशीन को अटैच कर देना और रेडियोग्राफ्स हो जाएंगे. We have given demonstration to some of you. Others, when you come to department, will give demonstration. It will be very easy. So the advantage of this technique is it is very easy. It is very simple to use, very easy to use. You will always get a good quality radiograph because there is no human intervention. Means no brain, your brain is not required to be used there. The machine will tell you everything how to make radiograph. Okay, so we end up with good quality radiograph, easy to do, not technique sensitive. Okay, but what are the limitations? Limitations are first the limitations of the oral cavity. The mouth, the palate sometimes may be shallow and it may not allow the film to be placed always at the 90 degree. Sometimes the floor of the mouth patient may have gag sensation and you will not be able to place the film holders. First thing. Second, the film holders are expensive. A set of film holder costs around good quality 10 to 15,000 rupees. So every time you may not have film holders available. Further, if you have multiple patients in the clinic, then you have to have either too many sets of film holders or a rapid technique of sterilization or disinfection. That also is a problem. Sometimes the film holder may get broken down. No, you are using it, it fell on the floor, it broke. So there is a limitation of logistic. Then in these conditions, the paralleling technique becomes a problem. Okay. So to remove all that, see, this is how the radiograph is made. Okay. The film has been kept and the film holder is kept and the patient is taking radiograph. It is very simple. We keep the film holder like this and this is the beam indicating device. Arrange the machine and shoot the radiograph. You don't have to use your brain at all. It is very simple to do it. Okay. These are for the different teeth, how the indications will look. Okay. Now the second comes is Szymanski's rule, the bisecting angle radiograph. So I told you what are the problems. The problems I told you in that was the limitation factor was the main one limiting factor was that we may not have the holder. The second limiting factor was that we may not have the patient's mouth may not allow us to make this radiograph. So to overcome that, this technique has come. In this technique, what we do that we keep the film in the mouth close to the tooth. We take the film and adapt to the mouth. So palate shallow हो या deep हो, उससे फर्क नहीं पड़ता है. हम फिल्म को हमेशा टूथ के क्लोज अडेप्ट कर सकते हैं कितनी भी डिग्री के एंगल पे. एंड इट इज कॉल्ड एज द वी कैन यूज दीज फिल्म होल्डर्स. ये देखा होगा आपने, इसे हम स्नैप ए रे फिल्म होल्डर कहते हैं. SNAP स्नैप ए RAY रे, स्नैप ए रे फिल्म होल्डर. या फिर ये हीमोस्टैट जो नॉर्मल अपने माउथ में जो अपने क्लिनिक में यूज करते हैं, हीमोस्टैट या आर्टरी फोर्सेप्स जिसे कहते हो, उसे भी आप यूज कर सकते हो फिल्म होल्ड करने के लिए. अधिकतर लोग फिल्म के लिए पेशेंट के फिंगर्स यूज करते हैं, बट वी शुड नॉट यूज फिंगर बिकॉज इफ यू यूज फिंगर यू आर एक्सपोजिंग द फिंगर ऑफ दैट पेशेंट टू द रेडिएशंस एंड radiation should be avoided as much as possible. पिछली क्लास में पढ़ा कि radiations are very harmful. So there is technique called Alara principle. It says, okay, there is something called as Alara. ALAR. Alara principle says that as low as reasonably achievable. मतलब जितना से कम हम एक्सपोजर दे सकते हैं हमें पेशेंट्स को देना चाहिए. That is why we should not use fingers. We should use the film holders. This is called a snap array film holder. SNAP 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 array film holder we call it. We can use it. Now see what is bisecting angle technique. It is very easy to use. I'll explain you in a blank slide. Wait. So we take this blank slide. Okay. See, I have told that there is something called as Szymanski's rule of isometry, which says that two triangles, if we take two triangles, okay, we take a triangle like this, okay, and we take another triangle like this. Okay, if these two triangles, if this side is equal to this side, okay, and this angle is equal to this angle, again this angle, if it is equal to this angle, it says then these two triangles will be equal to each other in all the aspects. Okay. It says that if two angles and the side between them in two triangles are equal to this angle is equal to this angle is equal to this angle, and this side is equal to this side, then these two triangles will be equal to each other in all the aspects. ये आपने पढ़ा होगा 9th 10th में मैथमेटिक्स में. ये दोनों इसको हम कहते हैं Szymanski's rule of isometry. Based on this rule, the bisecting angle technique is made. That is what we do, that we say we take a tooth. Sorry, my drawing is very bad, especially with this. Okay, so suppose this is the tooth. Okay, and
yes,
we keep the film here. Fine, and this is the film. So this is the long axis of the tooth, and this is the long axis of the film. If we extend it, it makes an angle. At some point it will make an angle. The long axis of the tooth and the long axis of the film will make an angle. Okay, this angle. Okay, so this is the angle being made. What we take, that we imagine a line which bisects this angle. Okay, we imagine a line which bisects this angle, and then what we do, that we position the X-ray cone in such a way. Here we position the X-ray cone in such a way that the central beam passes through the apex of the tooth and falls at 90 degree to this imaginary bisector. To this imaginary bisector, it falls at 90 degree. So now we are ending with one triangle. One triangle is starting from here. Okay, is starting like this. Okay. Yes, Rishiraj, please tell. Okay. One triangle is like this here. That is, I'll outline the triangle with another color pen. Is we'll outline with green. So one triangle is here, like this, formed like this. Okay, this one triangle is formed. This triangle has the angle which was bisected. This central ray bisecting line is parallel or common, and this was at 90 degrees. So this angle and this angle, and we have another triangle on this side. Okay, we have another triangle on this side. So we ended up with two triangles, one like this and one like this. This angle and this line are the imaginary bisector which are common. Okay, this a larger angle was bisecting into two angles, so these two are parallel equal to each other, and this was falling at 90 degrees, so these two angles are 90 degree to each other. So this triangle will become equal to this triangle. No, that's why the size of the tooth and the image of the tooth on the film will remain the same. Okay, I'll try to explain again, then you all will understand. So we have a tooth here. Okay, we have a tooth here, and this is the long axis of the tooth. Okay, we kept the film here. We kept the film here like this in the mouth. Okay, okay, we kept the film here. Now an angle is formed between the tooth and the film. Okay, when you keep the film in the mouth here, you can see that a film will keep here, an angle will be formed. That angle, you have to imagine that a line is there which is bisecting this angle. Okay, so this is the long axis of the tooth, this is the long axis of the film, and you have to imagine this bisector. Okay, we imagine that there is a bisector over here, and we have to drop the x-ray in such a way that the x-rays fall at 90 degree to this bisector. That means the X-ray are falling at 90 degree to this bisector. This bisector. So we are ending with two triangle. One triangle here. This is the tooth. This is the imaginary bisector, and this is the angle between the tooth and the film which was bisected by. So this angle will be equal to this angle because we have imagined the imaginary bisector. Okay, this line is common, this line is common, and this angle is 90 degree because we are dropping the x-ray beam at 90 degree. All this has to go in your mind. That means this triangle will be equal to this triangle. So if this is the size of the tooth and this is the shadow of the tooth form, so the size of the tooth will be, shadow of the tooth will be equal to the size of the tooth. This whole thing is called as the bisecting angle technique. This is the bisecting angle technique, or this is also called as short angle technique or short cone technique. Fine. Okay. So now, what are the benefits of bisecting angle technique? It is easy to. It is, we don't need any special device. हमें कोई बहुत हाई फाई डिवाइस नहीं चाहिए. अगर कुछ नहीं तो हम अपने आर्टरी फोर्सेप्स से ट्वीजर से फिल्म को प्लेस करके हम रेडियोग्राफ ले सकते हैं. बहुत बुरे कंडीशन में हम पेशेंट का हैंड रख सकते हैं, लेकिन नहीं लेना चाहिए. तो एक जो हमारी लिमिटेशन थी कि जो 15,000 का जो फिल्म होल्डर है वो हमें नहीं चाहिए. ठीक है, उसकी जरूरत ही नहीं है. स्टरलाइजेशन की, डिसइंफेक्शन की कोई जरूरत नहीं. सबसे बड़ा लिमिटेशन खत्म हो गया. लेकिन इसकी प्रॉब्लम्स क्या है? और दूसरी प्रॉब्लम थी पैरेललिंग टेक्निक में कि एनाटॉमिक कंसीडरेशन थी कि पैलेट शैलो है या फ्लोर ऑफ द माउथ शैलो है तो फिल्म नहीं टिकेगी. वैसा नहीं है, फिल्म किसी भी एंगल पर टिक सकती है. हमें इमेजिन करना है कितने एंगल पे और हम रेडियोग्राफ ले सकते हैं. लेकिन प्रॉब्लम क्या है इसमें, डिसएडवांटेज क्या है? एक, यहाँ पे सब कुछ हमें इमेजिन करके चलना है ना. वी आर इमेजिनिंग एवरीथिंग, वी आर नॉट यूजिंग. पैरेललिंग क्या था? गाइड था हमारे पास जो हमें गाइड कर रहा था. यहाँ हमारे पास गाइड नहीं है. अगर हमारे पास गाइड नहीं है तो देयर आर वेरी हाई चांसेस ऑफ एरर्स, देयर आर चांसेस ऑफ एरर्स. और दिस टेक्निक इज टेक्निक सेंसिटिव. ये टेक्निक सेंसिटिव मेथड है और इसमें बहुत सारी गलतियां हो सकती हैं. लेकिन एडवांटेज ये है कि हमें फिल्म होल्डर की, स्पेसिफिक फिल्म होल्डर की और लॉजिस्टिक रिक्वायरमेंट नहीं है. पहली, दूसरी, एनाटॉमिक कंसिडरेशंस को हम, लिमिटेशंस को हम बाईपास कर सकते हैं. माउथ ओपनिंग कम है तब भी हम रेडियोग्राफ बना सकते हैं, लेकिन हमें थोड़ा शार्प होकर रेडियोग्राफ बनाना पड़ेगा. योर इमेजिनेशन कैपेसिटी हैज टू बी good. That means it is a technique sensitive and there are more chances of you doing mistakes in this. So now we'll see something. Okay, these guidelines are there. Okay, what are these guidelines? That what happened that these guidelines have been given that we made multiple radiographs. Okay, some people made hundreds, thousands, 1,000, 2,000, 3,000, 500, thousands of radiographs they made. And what they found that while making a radiograph of maxillary incisor, see, if this is the patient's head, okay, and we take the film like this is called as a positive angulation. And if we keep the x-ray film, x-ray machine like this from down, if we give, it is called as negative angulation. Okay, so for lower teeth we have to give the negative, for upper teeth we have to give positive angulation. From upper teeth we look from the up, for lower teeth we take from the radiograph, we take from the down. So it is called as positive and negative. So for maxillary teeth, if we keep a radiograph at the 40-degree angulation, the X-ray machine will have an angles marked on it. X-ray machine में angles mark होते हैं. आप डिपार्टमेंट आओगे तो मैं आपको दिखाऊंगा. तो +40 डालेंगे तो सेंट्रल इंसाइजर, लेटरल इंसाइजर के रेडियोग्राफ अच्छे आ जाएंगे. अगर हम 45 डिग्री लेंगे तो कैनाइन का एंगुलर रेडियोग्राफ अच्छा आएगा. If we place 30 degree, we'll get a good radiograph for the premolars. If we place 20 degree, we get a good radiograph for the molars. Same way, 15-degree mandibular incisors, 20-degree mandibular canine, -10-degree mandibular premolars, and -5-degree mandibular molars. Okay. And one more thing. Let me find some lady with a face. Yes. Okay. See this lady. Okay, now the one was that will keep the 40-degree like this, but where at 40-degree, so we take two few guidelines. Okay, one line is called as ala tragus line. This is the ala of the nose and this is the tragus of the ear. Okay, this is the ala of the nose and this is the tragus of the ear. So we imagine a line called as ala tragus line. And for central incisors, the beam for maxillary, it has to be pointed at the tip of the nose. For lateral incisor also at the tip of the nose. For canines, we give 45 degree, but where 45 degree हम यहाँ भी डाल सकते हैं, 45 यहाँ भी डाल सकते हैं, यहाँ भी डाल सकते हैं, यहाँ भी डाल सकते हैं, है ना. तो maxillary central incisor के लिए tip of the nose 40 degree. For canines, end of the nose or align medial canthus of the eye here. Okay, this point, that means at this point 45 degree. For premolars, a line running down from the pupil of the eye to where it bisects the ala tragus line. Okay, ala tragus line, pupil of the eye here at +30 degree. For molars, outer canthus of eye to the line meeting at ala tragus line. This point, outer canthus of eye till the ala tragus, यहाँ पे हम रखेंगे +20 पे, तो हमारा maxillary molar का आ जाएगा. Mandibulars के लिए हम इसको क्या करना है कि एक लाइन हम इमेजिन करनी है 1 centimeter above the inferior border of the mandible and parallel to it, and the same lines we have to draw downwards. Molar, premolar, है ना, canine, and tip की जगह पे center of the chin for the central incisors. So central incisors and lateral incisors, canine, okay, premolars and molars. But जैसे हम ऊपर आएंगे angulation कम होता जाएगा, आगे जाएंगे तो angulation बढ़ता जाएगा. We have to follow these lines, the point of entry and these angulation, and you'll always end up getting a good radiograph. Okay, so with this today's class we will end with the paralleling and bisecting angle technique. Okay, I hope you people have understood it. We have 4 minutes.
Sir.
So if you have any doubts, yes, sir. If you have any doubts, you can ask me on the WhatsApp, and I'll make a note and send to all of you. Okay. Fine. Have a nice day.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Good evening, sir. Thank you, sir.
Thank you, sir.
Thank you. Thank you.
Thank you, sir.
Thank you, sir.